Now, some words of introduction before officially get started. You can choose to listen to the English translation by you clicking on the icon at the bottom of your screen, and you will be able to follow the discussion on the social media, and you can use the tag of the day, Zero Discrimination Day, and you can also put your questions in the chat. The most recent data show that back in 2020 in France, there were more than 172,700 people living with HIV, and most of these people have an undetectable viral load. This is in line with the 1990 targets of uh, UNAIDS. Though France is on the right track to eradicate the HIV epidemic, there is still a lot to do, and the COVID pandemic has, in a way, slowed down our efforts. The HIV positive people are asking us to uh, look beyond the undetectable viral load and to put the focus on their quality of life. HIV positive people, though they live longer, do not have the same quality of life as other people. This conversation arrives at the right time and will open a new chapter in the fight against HIV, a chapter that puts people living with HIV and their well-being at the core of priorities. The victories of the past must help us move forward, but should not make us complacent. Today, we will explore the policies that will contribute to improving the quality of life of people living with HIV in France. France has always been considered as a pioneer, a champion in HIV research. This event, as a consequence, comes at the right time as the French presidency of the Council of the European Union had set three priorities: well-being, health promotion, and prevention when it comes to the fight against HIV. This will give the necessary impetus to put the quality of life and well-being of people living with HIV on the political agenda in France and in Europe. Today, we will be able to share good practices. How can we measure quality of life? How can we collect data to inform public policies? Now, at the beginning, to kick off this seminar, we will set the scene and we will try to understand why health-related quality of life is important for people living with HIV and why it is important in a clinical setting. I'd like to welcome Armelle Genevois. She's in charge of the Solancy Association, and I'd like to uh, welcome as well Bruno Spier, who's the honorary president of AIDS. He's the research director at INSERM, and he's an active living with HIV. I've known Bruno within the AIDS Association for a very long time. That's why we have a quite an informal relationship, and I won't call him by his last name. So we will also have a question and answer session after we have set the scene. Now, my first question to you, Armelle and Bruno, what do we know about the quality of life of people living with HIV in France? What are the good practices in France that could be transposed to other European countries? Armelle, first, perhaps. Good morning. Well, first of all, let me say a few words about Solancy. Solancy is an association that celebrated its 30th birthday during the COVID pandemic, and today we do note that quality of life of people with HIV is deteriorating. Very often, these women have experienced migration, have experienced traumas, and the access to the residence permit that would grant them some stability is difficult to obtain, which leads to many difficulties in getting access to health rights. So these populations that we work with have a greater life expectancy. However, their global health, their general health is quite altered because of their living conditions, because of the traumas that they have experienced. Some of these families live in hotels or in hosting centers, and also experience the digital gap. They have a hard time getting an appointment at the doctor, and well, this makes it difficult for them to access specialist healthcare. And well, today, we promote healthcare at different levels: dental care, gynecologist care, and other type of care whose access are quite easy for most people, but not for those people that we work with within the association. In France, we have many cross-cutting studies and cohort studies that have helped us measuring the quality of life with those people. And we have noted that when the antiretroviral therapy arrived, the quality of life improved, and we noted that the quality of life of people living with HIV remains lower than the quality of life that other people from the general population benefit from. Stigma, discrimination also account for the fact that the quality of life of HIV people receiving a treatment is not as good as the quality of life of people who are HIV negative. Now, one of the good practices in France is the healthcare system, which is free of charge, open to foreigners, even to irregular foreigners. And of course, we would like and we needed to maintain this access, this universal access to healthcare, in spite of the fact that some candidates running up for the presidential election are asking to get rid of it. Now, it's true that not the different European countries not do not have the same type of healthcare system. So yes, I agree with Bruno. We must maintain and we must strengthen our healthcare system in France, but we go beyond the undetectable viral load, and we must give greater attention to long-term well-being of people living with HIV. Now, how can we make this change? How can we make this shift happen? Now, I think that first and foremost, we need to address the causes for which these people have a lower quality of life, the structural causes, the causes of discrimination that impact the quality of life. We need to act against the xerophobia, as we call it. Today, when you are HIV positive, it is very difficult to say it. You don't tell people that you are HIV positive, though the situation is a bit better than it was 20 years ago. It is not perfect. Then we must also act on the quality of life of people. um, Various people living with HIV live in precarious conditions, in very hard conditions, and the quality of life is about well, housing, family care, children care, and then as this has been enhanced by the well, we could imagine better treatments, better therapies that would help people live longer and have an easier access to healthcare. Perhaps this would also help people living with HIV. Okay, we need indeed to change mentalities, mindsets. I know of a mom in the association who said that, well, HIV still kills because of the way people look at us. And people, of course, continue to experience discrimination, a stigma, and a and hardship for people that are HIV positive. So we need to work on the mindset of people. I think that we need to work at different levels, at micro, micro levels, and we must coordinate our action. We must also act on public policies, gather information about good practices at the international level, and I think that we will need to work with partners who are not directly linked with HIV, but also with the living conditions of those people that we give support to, as we have said. And we also need to work with healthcare professionals, with doctors, and approach the the healthcare from a global point of view. Bruno, I have two questions for you. What is the relevance of healthcare in clinical research, and how can we make sure that it is better taken into account? Now, I think that within the clinical research, we need to include the way patients perceive their illness within clinical trials, or when we test molecules. We must give patients question forms to understand their quality of life and to implement the right policies, the right provisions, and take the right actions. And I'm sure that Diana will say a few words about this.
So, according to you, what are the obstacles to improve the quality of life of people with HIV? There are many obstacles. First, industrialists have also to introduce such indicators when they develop their molecules. And until now, quality of life was something at all. So at the very beginning, when you develop a molecule, you have to think about the people, the way in which they live, the people who are on the trial. But regarding regulatory authorities, they also have to be very clear, and they have to ask indicators that the industry could introduce to explain a higher why the price of the drug is higher or why the service is different. And until now, the quality of life is tailor-made. It means that depending on the medical innovation, the way in which quality of life is going to be impacted is different. We cannot have one single indicator that is going to work for all the molecules. So the industry has to, for instance, say, if I develop that molecule, it's going to have that impact on quality of life. And then, in agreement with health authorities, they should agree that such an indicator can show proof that this dimension of quality of life has been increased through this drug or scientific innovation. So today, health is more focusing on the long-term condition. You, Amel, you're working with kids with HIV and living with their families. So how have things evolved over time, and what is at stake? At the very beginning, Solancy created a creche, a garden, kindergarten services for children who are ill. Well, today things have changed because children, at least in France, are not that numerous to be affected. Now, of course, you can also have children who are not in France, who are still in the country of origin. But as I said, today things are different. We do not accompany children, we accompany them for problems which are not HIV related. We support them for other disabilities, but not for HIV related issues. And we also have questions about pregnant women. That's why we have a project on what we call perinatality, because we still have questions as to the transmission of HIV for the baby. So we still have a lot of questions, even if the medical world is reassuring, you still have this fear. And the work of psychologists, especially when it's the first pregnancy, is very important. So it's everything which is related to the impact on the life of the baby. Can we also take medicines or drugs during the pregnancy? Then we also have the issues around breastfeeding. If I don't breastfeed, am I really a good mother? And questions of the kind. This can seem to be an anecdote, but it's not. It's really essential for young mothers who have a lot of questions about their role as a parent. And that's something we have to do. We really have to take care of the families. Of course, it's a long condition, but as we said, it's different from the others. In the past, we were referring to life and death. Now we talk about social survival. Today, we talk about a global health of a good quality. We want to have access to specialized care, gynecologists, dentists, and of course, this is these are questions that we have to tackle today. And even if we have the same structure for the last 30 years, things are different. We do not address the same questions today. So we are not there to support children who are ill, but we are there to support people with a lot of vulnerabilities. In the past, parents were going to the hospital for heavy treatments, but today it's different. It's more an integration into social life, which has become difficult. Thank you for this very strong reminder. A last question. What about the importance of integrated care centered on the person to guarantee a long-term well-being for people with HIV? Well, the idea is that the health pathway, care pathway would be simple. It is already very complicated to have appointments, to be able to take the drugs, and when the people get older, they going to have other health issues and go to other doctors. So if each time you have to tell the same story, if there is a lack of coordination, if you have to tell the same story to different doctors, it becomes even more difficult and complicated for people. So the fact of having a coordinated center, everything at the same place, is something that should make things easier. Thank you. Let us now move to the second topic of the day. So the idea was to know how your work is impacting the quality of life of people with HIV. Now, for the second part, we have more or less 1 hour. Let us together see how we can improve the quality of life of people with HIV. With HIV outcomes, we want to identify very practical actions, very practical things that French decision makers could do to make sure that the fight against HIV becomes a priority in Europe. We have to make sure that needs of HIV be visible and taken on board in the long term. We want to better assess the quality of life of people with HIV and see whether there is a strategy to speed up the way in which we can meet the needs of people working with or people living with HIV. First, I would like to welcome Florence Thun, who is General Director of SIDAction, and she's also living with HIV, and Diana Berger. She's a postdoctorand and researcher at the Bordeaux Population Health Research Center in Bordeaux. And I've been an activist with Florence for many years, and that's also why I'm calling her by a first name, by Florence. So first, a very short question to Bruno. Bruno, how can communities and public authorities in the wide meaning of the word, how can they better work together to develop and implement effective strategies to improve health-related quality of life? Well, when you have people with HIV, you have different subpopulations. And to me, the role of associations is to identify the needs in terms of quality of life and to make sure that public authorities undertake the appropriate actions regarding care, but also availability of drugs. Let me take a very recent example with the ED Association. It was regarding the new drugs which are currently discussed very much, the new injectable drugs. They could improve the quality of life, but it hasn't been demonstrated by laboratories. But in fact, neither labs nor public authorities had asked the opinion of the first who are really involved, concerned, i.e. the patients. And we carried out a small survey with our different associations through our journal which is called Remède and which is read by a lot of people with HIV, we asked the question, and half of the readers were interested in obtaining such injectable treatments, especially amongst the most precarious subpopulations. Because when you share an apartment with other people, you do not necessarily want to disclose your HIV status. So they prefer to have this injectable drug or medication. So this is one example amongst others. But we are there to identify the needs and to do real advocacy for people with HIV. Florence, what is the impact of stigma and discrimination related to HIV regarding the efficient implementation of policies at a national or international level? Well, hello to everyone. This is, of course, a very wide issue, a very wide question, which is well known and which is true at all levels, local, national, international level. A report in 2017 had been published on discrimination and stigma that prevent people from going to the screening centers or by going to by asking for care. If people have the feeling that they're going to be judged, that they're going to be discriminated upon because they have HIV or exposed to contamination risks, of course, it will not go to health structures. And this is human. We do not want to say or to expose the fact that we've been contaminated, that we have HIV. So regarding access to care, and this is something we can see in countries where people with HIV are stigmatized, or people or drug addicts using injectable drugs. Well, they do not want to be stigmatized by going to a doctor because, of course, they know that they're going to be judged and discriminated upon. So this is something which has an impact on the care pathway. We all know that this is very true. But we, as people with HIV, sometimes you also enter into these discrimination debates. Let me take an example. The fact that we have an undetectable viral load and hence not transmit the HIV virus. There might be a risk of discrimination between those who have an undetectable viral load and the others, which do not have this undetectable load. So that we run a risk of having a discrimination between both groups. So discrimination and stigma, these are things that we have to tackle, but we also have to pay a lot of attention to not in turn be showing discrimination amongst ourselves, as I just said. Diana, hello to you. My question is going to be very direct, very simple. According to you, how can we measure the health-related quality of life of people living with HIV? Well, I am a researcher, so I might have a different angle or approach than the previous speakers. But this is very, very wide. We encompass the physical health of the person, the level of independence, personal beliefs, and also the relations with the others in the environment. So it's a very complex issue. And we have standardized questionnaires which use this or which try to capture this multidimensional concept. Most of the time, such questionnaires are going to be filled in by the person herself. And we also have very specific measurements and generic measurements. For instance, generic measurement means that this is something that we can use amongst the population at large. So, as I said, people are going to fill in the questionnaire by themselves. And what are the dimensions which are necessary for this tool to be efficient? First, and of course, we have different levels because Bruno already referred to the clinical research, but we also have public policies and the way in which quality of life is going to be taken on board. After having listened to everything people said, the multidimensional quality of life has to be integrated into this monitoring. So social dimensions, for instance, the relations you have with the friends, the family, the sexual life, also life, living conditions, access to transport, to leisure. And to come back to what Florence said, the way in which you live your health issue, the way in which you assess your health problem and you are uh, experiencing it, it also has an impact. Okay, so what are we going to do with all these data? How can such data have a real impact? How are they going to be taken on board in public policies? This is, of course, a huge question. We have other examples in cancer treatment, for instance. So we can use such data at different levels, at an aggregated level, to improve quality of care, or in a non-aggregated way. So we have the interface between the carer and the patient, and we use the data to improve the communication channel between the doctor and the patient. And it helps us to better identify some fears and be more efficient, focus our work on what really is considered as being a source of discomfort by the patient. Then we can also use it as at an individual level. Means that what matters for the doctor, for instance, the doctor is going to look at the latest biological balance and look at the viral load, and for the doctor, everything seems to be all right, but for the patient, not. Within this appointment with the doctor, the patient should be able to talk about different problems regarding, for instance, his sexual life, or the fact that he really has the feeling that he's alone. So loneliness and other sources of discomfort should be taken into consideration. While listening to you, do you think there is a real change in the way in which public authorities are addressing the issue? And how is this going to have an impact on the different policies? How can things evolve in that direction?
So there is the issue of implementation. We do see that in hospitals, there is the interface between the carer and the patient. What matters most is the structure, the uh, dimension in which the care occurs. So we need to focus on social, mental, and physical dimensions. Now, of course, we need clinicians to endorse this way of uh, functioning, and we need them to adopt the tools that we put forward. We need to see what we will be doing with the data, how we are going to handle them with care, with patients, with policymakers, and see what are the dimensions that are mostly identified in this pathway and relationship between the care and the patient. At the Denver Convention back in 1983, the HIV patients said, there's no way you can fix our problem, but you need to listen to us at least. Building public policies with patients and for the sake of patients, it's crucial. And I have two questions about this. Is it something that we do? Do we build policies and care policies for the sake of the patient? And how can we improve these public policies in the way that they are elaborated? Now, of course, in the French-speaking countries and in France, policies are not built sufficiently for the sake of the patient. And this principle was voiced by disabled people in the 80s. They've also said that public policies needed to be built for them. However, we must continue fighting in France, but also in other countries where healthcare democracy is not at its best. You were asking what are the good practices that we have in France that could be transposed in other countries, but I think that France has also to take inspiration from other countries, from Canada and other foreign countries. I think that generally speaking, since the Denver Convention in 1994, the Paris Statement also enshrined another principle, the GPA principle, that would give a greater say to HIV positive people in building public policies. We also worked on the GPA principle and saw how we could give a more meaningful participation, a more meaningful involvement to um, HIV positive people. So I think that we have heard nice statements, but unfortunately, these are not always properly enforced. Now, there was back in 2017 the Paris Declaration that included HIV positive people or people being at risk of infection. This declaration was signed by some members of the medical community, and we also had some HIV positive people t- having a say uh, before this conference. And as far as we are concerned, we as activists acting to fight HIV, we are still uh, quite angry because we do feel that HIV positive people are not sufficiently listened to. Not so long ago, a roadmap on the national strategy on sexual health was defined, and the word HIV is mentioned 117 times, but it there is only one occurrence in which people living with HIV are referred to and included. So quality of life in this strategy is unfortunately underestimated. And this means that we need to better train nurses and healthcare professionals about the quality of life. Now, of course, sexual health is also very important for including for HIV positive people, but quality of life and understanding what the HIV positive people need in terms of drugs, in terms of cure, in terms of treatment. Perhaps in the English speaking countries, the work within the communities is more intense than it is in France. We must also say that national policies should include HIV positive people or people exposed to the HIV risk. At SIDAction, we've been working a lot with children, with care for children of HIV positive parents. And within our board, we have people, HIV positive people. We also need to listen to the needs of the younger generations. And we must pay close attention to giving and hearing the voice of the younger generations and not of all the same people. So it all starts with the needs of the people, of people who are not part of the associations. What do you think are the good practices from Canada or other countries that could inspire us? Now, involving chronic patients, not only HIV patients, and healthcare professionals, it's key in everything that has been said, and listening to people, listening to patients, paying attention to their quality of life. I think that training healthcare professionals is key. We must improve the training of healthcare professionals. And I think that Canada has moved forward and advanced a lot on training. If healthcare professionals are properly trained and undergo CPD, continuous professional development, well, perhaps patients will be better listened to. Now, before giving the floor back to Bruno, I have another question for Florence. What is the role that the community should play to measure the quality of life of people living with HIV? I do agree with Bruno, involving associations, hearing the voice of patients that are part of association, as we do at Solancy. Listening to those people is something that we do at SIDAction. For a long time, we have funded projects on quality of life. We have a wide array of measuring tools, and we ask associations at SIDAction to assess their programs and projects, and we noted that associations needed to use these tools even further to make sure that patients were comfortable in using these tools. Now, being involved in the decision making process is time consuming and is costly. Now, for patients to be given the right role, we need to have time on our side, we need to have financial means, and our communities are quite diverse. So you said that in France there are 173,000 HIV positive people, and these are 173,000 different stories, different backgrounds. And those people, they do not have the means to come to meetings in Paris or to attend meetings organized by associations. So I think that we have to help these people in having the opportunity to take part in associations work. Now, Bruno, let me come back to you. And well, we know that the HIV research has benefited from the research on COVID-19, and let's hope that the opposite is true as well. Now, how do you think that research on COVID can further help the research on HIV? You know that people who researched COVID-19 were also involved in the research about AIDS, about immunology, virology. All the research around immunology and virology could be applied to the research on COVID through the uh, the technology, through the cohort of patients, the methodology centers that allowed us to follow cohorts of patients. In France, we also cooperate with developing countries in Asia and in Africa, and we could tap into these research centers to favor the research on COVID-19. So it is true that the research on HIV/AIDS has helped a lot and benefited the research on COVID. And Tony Fauci, the American doctor in charge of the COVID-19 pandemic, was a very prominent researcher on AIDS. So this is very good for COVID. It is less good for um, HIV/AIDS because you cannot do everything at the same time, and there is still a lot of work that needs to be done on HIV. We have no vaccine. We have no cure because, well, we you don't recover from HIV yet. Now, as a researcher and as an activist, Bruno, what was the impact of the health crisis on the care given to HIV positive patients? Now, in France, data shows that as far as immunological parameters, there was no impact. So HIV positive people still were still able to access treatment, were still able to see their doctors, sometimes through a video call. But the COVID-19 pandemic did not put an end to the access to treatment. However, when it comes to comorbidities and access to hospitals, well, and we know that some comorbidities can be very serious. Some of them are cancers, and perhaps these cancers have not been diagnosed in time. So, yes, perhaps there has been an impact on the uh, the care for comorbidities. Now, there has been also an impact on screening. There is less screening. There was less screening during the COVID-19 pandemic, and less screening means more contaminations potentially, because if you're not diagnosed, you can transmit the disease without knowing it. And because of the pandemic, there was less action on prevention as well. Uh, uh, of course, perhaps uh, some hazardous behaviors have decreased. But yes, in a way, the access to care and the access to prevention was undermined in a way by the pandemic, by the COVID-19 pandemic. Now, the 2021 report of the Global Fund shows that HIV screening has dropped by 20%. However, the access to antiretroviral care has increased by 9% thanks to community screening. So, Armel, let me come back to you. What what was the impact of COVID-19 on the care given to HIV positive people? As Bruno said, people continue to access treatment, and even thanks to their pharmacist. So we did not see any negative impact. However, we noted that some people were afraid to go to hospital because they feared being contaminated by the coronavirus. So there were perhaps indirect consequences on the mental health of the families of patients who felt more isolated. This is true. Now, of course, families continue to come to the association, and they were welcome at the association, but some of them did not want to come because they feared contamination, which means that their living conditions went down, and some of these families were left without resources. Fear of COVID, fear of the future, more isolation, and as a family, when you live in a small 15 square meter apartment that you never leave because of the fear of being contaminated, leads to consequences, which means that today we must bring back these families within the association, we must regain the trust of these families. We have put an end to collective action during the pandemic. We will, of course, start these actions again. We now see the consequences of the pandemic. We only see them now, and we do see that there are new comorbidities emerging, care that has not been given to overweight people, for example, who are even more overweight today than they were before the pandemic. So the health of some of these people is deteriorating. I mentioned a project on maternal health and infant health earlier. We wanted to work on the image of pregnant women. We wanted to focus on the quality of life of and the well-being of people. But people are very tired, they are exhausted, and during the lockdown, the municipal services stopped, and there were some care that were stopped during lockdown, and municipal services changed the way they operated. They changed the way they gave people appointments, and these dematerialization and digitization of services is preventing some people to access these services. Quality of life is depends on a number of factors, and we continue supporting families and their children, and some of them are in very difficult situation, and we do not realize to which extent some of these families live in very poor conditions. This is something which is unprecedented. So yes, we need to improve access to care, but this requires tackling other healthcare policies, migration policies. I think that we need to collect more information, as Bruno said, but we need to see how we can collect this information. So collecting information is time consuming, it is costly, and as Florence said, we try to develop other types of care, training of expert patients, and this is very complex.
It's a lot of energy which is required. We have to invest into activism, into associations, lives, and sorry for being a bit long. Before, because we still have 15 minutes, 15, 20 minutes. So before this round table, I asked you to identify one action, one priority action for France regarding the quality of life of people with HIV. So I would like you to give me this one priority. But before, I would also like to say that for this roundtable, we invited some political representatives, but of course, because of the international situation, it was quite difficult for them to attend the meeting. So, if you were to meet a representative of the government or a political decision maker, what would you ask that person? What would you ask that person to do as a priority? Let us start with Florence. It's difficult to limit to one priority because we have so many priorities. I would insist on the training of health professionals, because this is important, of course, because those people are going to later to enter into maybe retirement houses or old age houses. So we have to focus on the training, on the education of health professionals, because this is true for all types of health issues. Here we are dealing with HIV, but it's of course much wider. We have to empower them. We have to make sure that they are really having a voice, that they can express themselves in this dialogue. It's sometimes quite difficult. We don't have time to talk about health-related issues and quality of life. So, Florence, what about you? I will stick to my hat of researcher and focus on the impact of the crisis on research, because of course we've been very much impacted by the fact that we were all teleworking, that we didn't see one another anymore, and that all the priorities went to the COVID research. So today we are still trying to improving ourselves, and we have also to look at what is taking place in other countries. In other countries, things have been accelerated, especially in the field of public health, taking on board different dimensions of health issues. And this has to be more or less at the same level as biomedical research. And you, Bruno, if you were to meet Olivier Véran, what would you tell him? I would like to look at everything that has been done in the field of HIV research, actions of associations, the way in which they we have to focus our work at a horizontal level. And we also have to draw lessons from other countries. Today, these are things which have not been taken into account in the management of the COVID crisis, because nothing has been developed together with the people, with the population. And this is what led to a lot of frustrations. If we had something, a concept as health democracy, I'm sure that it would have been much better, not only for HIV people, but for everyone. As a coordinator of a European platform with 6 European countries, I can tell you that this is a problem with European governments. No one listened to community associations. So no one asked our opinion. We have 40 years of experience in working with the HIV community, and they did not listen to us to manage the situation. And what would you tell him if he were to be here, Mr. Véran? Well, as I said, there are things that have to be dealt with by the Ministry for Internal Affairs and not the Ministry of Health. We have to work with doctors, with caregivers, and we also have to identify the work of what we call health mediators, because they really have a role to play today. It would be great if we could focus more on this cooperation and make them more visible. We also have to continue to reinforce the health pathway, in other words, and make sure that young health professionals are really facing what is going on in the field, the reality, not only simply the fact that we announce a diagnosis, but all the rest, everything which is related to that diagnosis, all the impact on the family, on the parents, on the friends, and everything. Yes, I think that Florence agrees with you because she showed her thumb up. A very, very last question before moving to your conclusions, i.e., one thing that we should consider as a priority. So United Nations AIDS wants to put an end to the HIV virus. And what do you think about that? What do you think about that goal? And what do you think about the impact of COVID regarding that goal? It's something which is a bit outside of the quality of life framework. But what do you think about that? Bruno, what about you? Well, we want to improve what you want to 2030 and this objective by um, United Nations AIDS. Do you think we're going to reach that goal? Well, I don't have a crystal ball. There are so many uncertainties in the field of the health crisis management and all the rest. It will all depend on us, on our capacity to go together. We will only be able to reach our goal if we are there, if we are present, if we exert pressure. Otherwise, it won't be the case. So it will depend on our capacity to go together with more people, and we have to make our voices heard. So to conclude, let me go round the table again. If you were to identify one priority, one key step in France to focus on the quality of life of people living with AIDS, with HIV, to move to go in the right direction, what would be this step? What would be this priority action? I thought I had already answered the question earlier on. Sorry. Yes, but we wanted to conclude with these priorities, with your 5 priorities, and these will really be our conclusions. I would like to come back to what Armel said earlier on. Today, we have to put more money into the training and the education of health professionals. We don't have enough doctors or researchers in that field. We also have to focus on mediators. Health professionals are not always available. So between ourselves, between peers, between mediators, sometimes it's more efficient, it's easier. Mediators are also key actors to pass on the information. Quality of life, of course, is related to stressful elements, and mediators are closer to the population. So they are able to pass on the information and hence improve the quality of life. So we need to reinforce the funding of health mediators. Diana. Let me come back to what I said earlier on. We know that despite access to treatment, there is a poorer quality of life amongst the people with HIV compared to the general population. Mental health and psychological health is the most affected. In our research work on quality of life, we also conducted a survey on depression, and we compared the data with the French population as such. And we've seen that no progress has been made for the last 10 years. So this should be a priority action. So we have screening tools, and this is something on which we could work based on our care structures. We also have to take on board social framework, social conditions, and relationships are very important. So we have to focus on depressed mood, relations with others, and go against stigma and discrimination. Armelle, your priority? Difficult to say, because everything we said could be considered as a priority. It's difficult to just focus on one priority. We have to listen to what associations are saying, because very often they've been pioneers. They have been the first to focus on a certain series of things. So associations are a kind of laboratory to improve the quality of life of people. So political decision makers should take on board all the signals that we already launched over the past. And these are alarm signals that we have triggered as associations. So there are many things, many data, and we should use them. It would be good to put together all the goodwill everywhere and do something. And what would be the priority that you would defend at any cost? We have to say that when you are on treatment, you do not transmit, you do not contaminate other people. That's something that we should advertise much more, because this is at the origin of a lot of problems and xerophobia. But there is a lack of willingness from public authorities to communicate about that, because, okay, they are saying we should fight against xerophobia. That's true, but even doctors do not necessarily communicate with their patients. Today, in 2022, you have patients who just realize that they are not going to transmit the virus just because the doctor did not inform them. So that's a real problem. This should be a priority regarding our public communication, to fight against xerophobia and to improve the quality of life of people living with HIV. This is true. It's true, because it's something that we were not able to do in France. We have to work much more on this communication. I would like to thank you. Thank you very much for this very enriching exchange. Thank you for your time. I know that it's difficult for everyone, so thank you very much again. HIV Outcomes really wants to do more regarding quality of life and health-related quality of life. So the discussion of today is going to enrich our advocacy work vis-à-vis political decision makers in France and at a European level. We would focus very much on this European dimension. So again, thank you. Thanks to all of you. Thanks to the technical team and thanks to the interpreters as well. And finally, to conclude, despite very sad international context and the fact that, of course, priorities go towards something else, today is an important day for the fight against HIV because we have three round tables. At noon, we have another one, unfinished business on HIV/AIDS, closing the policy gap to reach populations within the EU. So this is between 12 and 1:30, another round table, and I will be a speaker. And then we also have another round table with UNAIDS on another issue addressing inequalities from a human rights perspective. So if you have time, I would encourage you to take part in those round tables. Again, thank you very much. And as we say, the fight goes on. See you later. Thank you.